Hello people, this is Dr. Muskaan this side and I'm going to discuss one case with you. Here is 72-year-old female who has came to ER with chief complaints of fever which was on and off, vomiting, cough with white sputum, pain in abdomen and chest and loss of appetite since 1.5 months. On arrival, ABCS was done, airway was sprayed on breathing assessment, respiratory rate was 20 per minute, SpO2 was 66% on room air. So in order to maintain the saturation, we have given 4 liter per minute oxygen via nasal prongs and SpO2 was maintained to 98%. On circulation assessment, pulse rate was 105 per minute, BP was 108 by 67 mmHg, sensorium was alert, GCS was 15 by 15, E4, V5, M6, that was I was opening spontaneously, verbal response was oriented and she was obeying commands on motor response. HOPI, patient was apparently all right 2 months back when she 1.5 months back when she started having cough which was productive in nature, whitish in color, non-blood tinge, intermittent and correct turn, worked on biomass, that is chula, for 30 years. She has also complained of fever which was on and off in nature, associated with occasional vomiting, shortness of breath, increases on exertion, diffuse chest pain with epigastric pain. There was negative history of seasonal variation, diurnal variation, dust allergy, MDI, DPI use, that is meter dose inhaler or dry powder inhaler, steroid use, type 2 diabetes mellitus, hypertension, thyroid disorder. Past history. There was history of TB contact with the daughter-in-law 30 years back. History of TB to her own self 20 years back. Cataract surgery 10 years back. Personal history, she has addictions for BD smoking, 1 bundle BD per day from past 40 years. She stopped smoking BD since 1.5 months. She has no addictions of alcohol or tobacco. She's vegetarian by diet. Bowel and bladder habits are disturbed. She's not able to sleep properly at night. On examination, decubitus was she was lying comfortably on bed oriented to time, place and person. She was maintaining 100% SpO2 on 6 liter oxygen via oxygen mask. Vitals, BP was 91 by 57 showing hypotension, pulse rate was 105 per minute showing tachycardia, respiratory rate was 25 per minute showing tachypnea, SpO2 was 100% and temperature was 98.4 degree Fahrenheit. To your acknowledgement, pulse rate, normal pulse rate lies between 60 to 100 per minute. If it is more than that, it's tachycardia. Normal respiratory rate lies between 12 to 18 per minute, but if it is more than that, it is tachypnea. Parallel was present, edema was present, icterus clubbing, cyanosis, lymphadenopathy was absent. On systemic examination, CNS examination, she was conscious, oriented to time, place, person, GCS was 15 by 15. CVS examination, S1, S2 were loud. On respiratory examination, bilateral crypts were present in the inframammary region and crypts were also present on the apical region, which are the typical findings, auscultatory findings seen in the tuberculosis patient. On per abdomen examination, abdomen was soft, non-tender, not distended. Sorry. Investigation picture shows she is anemic. There was deranged KFT showing us AKI because urea was 49.8, sodium was 133, albumin was 2.2, alkaline phosphatase was 144, RDWSD, that is red cell distribution, width was 68, which is highly suggestive of iron deficiency anemia. Urine routine examination was normal. Ultrasound whole abdomen shows cholelithiasis, minimal fullness in the right pelvicecal system and minimal left pleural effusion. Amylase level and lipase level were normal, so we ruled out pancreatitis. Tropical fever tests such as dengue test were negative. HBS, HBC, HIV 1-2 were non-reactive. Typhi.IgM was positive. Yeah. NT-proBNP level was 16646.13 picogram per ml, suggestive of cardiovascular disease. AVG was normal. On chest X-ray, I can see pleural effusion on the left side because there was blunting of the CP angle. There was marked nodes. There was marked bronchovascular markings. Bottle-shaped heart was appreciated. So my differential diagnosis in this patient was old pulmonary TB activation because there was classical history of fever, night sweats and weight loss. There was presence of heart failure also, because according to the Framingham criteria, one major plus two minor, when how we make the diagnosis, there were presence of major criteria, that was orthopnea, and minor criteria, that was dyspnea on exertion, nocturnal cough, pleural effusion, tachycardia, and ankle edema. So when echo reports came, it also favored my diagnosis towards systolic heart failure. Sepsis protocol was there. Sepsis was there because there was hyperthermia, tachycardia, hypotension, and infection was also there because of mild leukocytosis. There was no severe sepsis because electrolyte levels were normal, and there was no such means it should be more than 4 if we say severe sepsis, and persistent hypotension were also there, which was not there. And COPD will be my another differential. Why? Because there was a classical triad present in the patient of the cough, sputum, and dyspnea on exertion. And my COPD diagnosis was also supported by the chest X-ray showing hyperinflated lungs with water-shaped heart. Plus, there was history of BD smoking also from one bundle from past 40 years. There was AKI because of the deranged KFT urine. Input was 1800 ml per 24 hour, and output was 450 ml per 24 hour. So the treatment given to this patient was injection clindamycin, which was a treatment for sepsis, LRTI, injection perinom, which is metoclopramide, which is treatment for nausea, vomiting, tablet EZI, which is macrolide antibiotic, which is treatment for respiratory infection, syrup aerodol, which helps to loosen thick mucus and making it easier to cough out. Injection formonide, which is typical treatment for COPD. Nebulization with Nebzmart, which is a treatment to relieve cough. Nebulization with 3% NaCl, which is a treatment for bronchiolitis or bronchiectasis. In NaCl is strong sterile solution. Steam inhalation is given, which helps to loosen mucus and decrease irritation in your sinuses. Nebulization with mucomyst was given, which helps to loosen mucus. Injection monosep was given, which was treatment for bacterial infection. Injection mycopharv was given, which was a treatment for iron deficiency anemia in 100% NS. And fluid therapy was going on, that is IVF, DNS, NS at rate 40 ml per hour, which was tapered to 30 ml per hour. Yeah, so it was a good case. That's all. Dr. Muskaan is signing off now. I hope you have also enjoyed listening to the history of the patient.